Hello, my name is Jorge Machicado, and I am an assistant professor and therapeutic endoscopist at the University of Michigan.
Hi, my name is Jean Chalhoub, and I am an advanced endoscopist at Staten Island University Hospital and an assistant professor at the Zucker School of Medicine at Hofstra Northwell.
In this video, we're going to be discussing our recent systematic review and meta-analysis on the effect of the number of passes on diagnostic performance of EUS fine needle biopsy of solid pancreatic masses, recently published in Gastrointestinal Endoscopy. Jan, tell us, what is this article about?
So, over the last decade, the development of new core biopsy needles has shifted the landscape of EUS-guided tissue acquisition. And as a result, needles have been preferred due to their higher diagnostic accuracy and sample adequacy when compared to FNA needles. With the novel FMB needles, the addition of rows does not seem beneficial. However, the minimum number of FNB passes to obtain highly accurate diagnoses when sampling solid pancreatic lesions during EUS with rows is unclear. Our study evaluated the impact of the incremental number of passes on diagnostic accuracy, tissue adequacy, and diagnostic yield when sampling solid pancreatic masses with FNB. For this purpose, we conducted a systematic review and meta-analysis of randomized controlled trials assessing per-pass diagnostic outcomes with any FNB type and with contemporary FNB needles, including both the fork tip and Francine needle designs.
And what do current guidelines say about the number of passes or benchmarks with EUS tissue acquisition of solid pancreatic masses?
Yes, there is no clear position on the minimum number of needle passes. However, in 2015, a joint task force from the ASGE and the ACG suggested benchmark parameters of at least 70% diagnostic accuracy and 85% tissue adequacy for EUS-guided tissue acquisition of solid pancreatic lesions. These benchmarks were developed during the era of FNA needles, and it's unclear if these benchmarks are adequate and representative of the higher quality of tissue sampling when using FNB needles.
Thank you, Jan. Can you share with us the key findings of the study?
Of course, when using contemporary needles, the effect of additional needle passes for diagnostic accuracy and yield plateaued after 2 passes, and the third pass did not provide any advantage. However, adding a third pass was shown to significantly increase tissue adequacy, which may have beneficial implications when tissue is needed for molecular profiling, as the field is progressively moving into precision medicine. It's important to note, however, that studies using contemporary needles did not assess outcomes after the fourth or the fifth pass. Additionally, when choosing any FNB needle, the incremental benefit of additional passes plateaued after 3 passes. Adding a fourth or a fifth pass did not provide any benefit on diagnostic outcomes. Importantly, the increase in diagnostic accuracy and yield when adding a second to a single pass was substantial, while the addition of a third to a second pass was only modest and may not be clinically relevant.
Okay, so when a patient presents with a solid pancreatic mass and the endoscopist decides to do EUS tissue acquisition with a fine needle biopsy and without any rapid on-site evaluation, also called as ROADS, what's the minimal number of passes that endoscopy should be performing?
So 2 passes with the Francine or fork tip needles and 3 passes with any FNB needle suffice to provide optimal diagnostic performance for EUS FNB of solid pancreatic masses without additional diagnostic benefits with more passes.
Given these findings, what's the position of the study about the use of macroscopic on-site evaluation, also called as MOS?
So the application of MOS in clinical practice can be cumbersome, especially when using the objective methods to measure tissue length. Only one study compared MOS and no MOS with 3 passes using a 22-gauge Francine needle and showed no difference in accuracy. It's unclear, however, whether similar outcomes would be obtained when 2 passes are performed, and such a study would be important. In the meantime, more data to support the application of MOS with contemporary needles is needed.
And finally, how does the study contribute to current society guidelines or benchmarks?
So the ASGE and ACG thresholds were achieved with a single pass using contemporary needles. Our results provide strong evidence to inform future quality metrics and guidelines on EUS tissue acquisition of solid pancreatic masses. The current benchmarks have been proposed around a decade ago, and updated thresholds are suggested considering the high-quality diagnostic parameters with contemporary needles. Our results also provide general guidance on limiting the number of passes, which has a potential to increase efficiency and safety, especially as additional unnecessary needle passes may increase adverse events and procedure duration without added benefits.
Thank you so much, Jan, and thank you to the GIE and HSGE for this opportunity to share our work, and thank you to all the viewers for their time.
Thank you, Jorge.